Hello, this is our presentation on spinal cord injuries. Please enjoy. Our case study is about a 20-year-old male that fell off a ladder while cleaning the eaves troughs of his parents' home 6 weeks ago. In his past medical history, he had cervical spondylosis, so he's been diagnosed with anterior cord syndrome. Here are our key terms. Traumatic spinal cord injury. Result from fracture or dislocation of the vertebrae which compresses, stretches, or tears the spinal cord. Transection. Severing. Complete spinal cord injury. Complete transections and lacerations of the spinal cord where there is very little to no sensory or voluntary motor function left below the area of lesion after spinal shock. Effects are permanent. Incomplete spinal cord injury. Incomplete lesion of spinal cord usually caused by compression trauma. Damage and level of recovery depends on the axonal/neuron tears/lesions on a microscopic level. Anterior cord syndrome. Incomplete spinal cord injury to the anterior portion of the spinal cord, usually caused by hyperflexion, compression trauma where cortical spinal tracts are predominantly affected, which leads to a low rate or motor function recovery. Spinal shock. Muscle flaccidity and loss of reflexes at and below the injured area seen immediately after a spinal cord injury caused by interruption of the autonomic nervous system pathways, usually 24 to 48 hours, but this period may extend for weeks. Post-spinal shock. Stage after spinal shock where reflexive functions return below the level of damage. It is at this stage that the extent of damage is gradually revealed. The ASIA stands for American Spinal Injury Association Impairment Scale, is used to determine the injury or if the injury is complete or incomplete. A, complete, B, C, D, and E, incomplete. Sacral sparing, partial or complete preservation of motor function, sensory function, or both in the S4 and S5 spinal segments of the cord. Tetraplegia or quadriplegia. Paralysis of all four extremities. Paraplegia, partial to full paralysis in the lower extremity. Etiology, causes. Anything that's in red is what is relative to our case study. Age, most in young adults due to high level of physical activity. Gender, male at 81%. Motorcycle and automobile accidents at 40.9%. Falls seen in elderly at 22.4%. Acts of violence, such as a gunshot wound, 21.6%. Sports-related injuries, such as diving or football, at 7.5%. And these percentages are based on both incomplete and complete injuries. Traumatic impact is a common cause of spinal cord injuries. Trauma can be precipitated by compression, penetrating injury, and hyperextension or hyperflexion forces. Damage to the spinal cord may be temporary or permanent. Here we have a little bit more of a visual for you. You can see the different percentages of the areas where the injury occurs and how it affects them in the paralysis of the rest of the body. Alright, so complete spinal cord injury. This is caused by complete spinal cord transaction or compression or vascular impairment. Sacral sparing is absence of any motor or sensory function below the level of injury, minimal chance of functional recovery, and ASIA results A, no motor or sensory function is preserved in the sacral segment. Okay, so now we have incomplete spinal cord injuries, such as anterior cord syndrome. This is caused by direct anterior cord compression, flexion injuries to the spinal cord, or thrombosis of anterior spinal artery. Sacral sparing is present, leads to variable paralysis below the lesion level with low or loss of pain and temperature perception. Dorsal columns, proprioceptive, and vibration sense are mainly preserved. Has a poor prognosis And the ASIA results. C. Motor function is preserved below the neurological level, and more than half of the key muscles below the neurological level have a muscle grade less than 3. These are just a few more types of incomplete spinal cord injuries to get you a little bit more familiarized with them. Here are some images to go along with those previous defined incomplete spinal cord injuries. Pathophysiology. There are 2 stages in post-traumatic period. In the early stage, spinal shock results from interruption of autonomic nervous system pathways by edema or hemorrhage which developed around the damaged area. It is characterized by flaccidity, areflexia, loss of bowel and bladder function, and autonomic deficits including decreased arterial blood pressure and poor temperature regulation below the level of injury. Lasts normally 24 to 48 hours and requires close monitoring. Level of injury cannot be accurately assessed during spinal shock. Complete spinal cord injuries. As spinal shock resolves, the extent of permanent damage is revealed, and neurological assessment confirms the complete spinal cord injury when sacral sparing is not present. For incomplete spinal cord injuries, as spinal shock resolves, reflex activity below the level of the lesion resumes, and undamaged tracts continue to conduct impulses. Neurological assessment for permanent damage may be done at that time to determine the type of incomplete spinal cord injury. So, for the diagnosis of complete and incomplete spinal cord injuries, physical and neurological examination and assessment of head and back at the emergency room. X-rays can reveal vertebral problems, tumors, fractures, or degenerative changes in the spine. A CT and MRI scan can define bone and disc problems. Neurological examination based on the ASIA impairment scale is performed after spinal shock is over to determine the level of injury. So some of the clinical features, observations that go with complete spinal cord injuries is complete transection or laceration of the cord, irreversible loss of all sensory and motor functions at and below the level of injury. And for incomplete spinal cord injuries, such as anterior cord syndrome, damage to the spinal cord is usually in the anterior 2/3 of the cord, and as a result of the flexion/compression injury. Motor loss below the level of the injury may be complete or partial. Cortical spinal tract is affected, and the chance of motor recovery is low. Dorsal tracts are spared and carry proprioception. Abnormal tone and muscle spasticity. Permanent effects vary among patients and depend upon the location and severity of the injury. Here are some secondary observations due to immobility and loss of function. Contractures from muscle spasms, bed sores, respiratory infections such as pneumonia, urinary tract infection, deep vein thrombosis, and sexual dysfunction. So this is our ICF model in regards to anterior cord syndrome. However, each different spinal cord injury has its own area of laceration to the spinal cord, so keep in mind the body and structure and function can be unique to each individual's case, and it will affect the activities and the participation of that individual. Treatment for spinal cord injuries. First aid, stabilization of the spine column by paramedics and the ER doctors to prevent further spinal cord or nerve root damage. Surgical, remove obstruction, repair damaged tissue, stabilize the spine, restore the alignment of bony vertebral structures, decompress neural tissue. Decrease intracranial pressure by providing a shunt for cerebral spinal fluid from the ventricle into the peritoneal cavity, and medical, glucocorticoids to reduce edema and stabilize the vascular system. The end. Thank you for taking the time to listen and watch our presentation.